Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on ART considerations in the inpatient setting, featuring Dr. Jason Schafer, who is a professor and vice chair at Jefferson College of Pharmacy, Thomas Jefferson University in Philadelphia, Pennsylvania. He'll take us through a case study of a patient with HIV who was admitted to the hospital, and we'll explore the latest data and recommendations for the use of ART in the inpatient setting. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Schafer.
Welcome, everyone, to this Key Decisions in HIV presentation. The title of this presentation is ART Considerations in the Inpatient Setting. My name is Jason Schafer. I'm a pharmacist, professor and vice chair at the Jefferson College of Pharmacy in Philadelphia, Pennsylvania. Let's begin our discussion today with a case study. This is a 49-year-old man who has sex with men living with HIV since 2014. He has a history of unstable housing and currently living with his son. He's virally suppressed on a regimen of darunavir, cobicistat, FTC, and TAF as a single tablet regimen. His comorbidities include type 2 diabetes, hypertension, and chronic kidney disease, and he is admitted to your hospital for new onset atrial fibrillation. His CD4 cell count is 590. His current HIV viral load is undetectable. His A1C is 6.4%, and his estimated GFR is 60 mLs per minute. He's on a number of other medications, including insulin, metformin, empagliflozin, lisinopril, and amlodipine. Patients living with HIV infection are certainly at risk for medication errors, especially during hospitalization and transitions of care. We know that patients living with HIV, when they're diagnosed, often may only be started on one medicine, but over time, as they age and develop other comorbid conditions, can be started on other medications from other care providers. They can also transition into the hospital and can be introduced to new chronic or perhaps temporary medications. And all of this can accumulate to polypharmacy for the patient. That can be an increased risk for medication errors, including ART omissions. They can be subject to an increased risk for drug-drug interactions, and these can especially occur during those transitions of care. Antiretroviral therapy stewardship can be key to ensuring safe medication practices amongst patients living with HIV infection. We know that errors, medication errors in particular, can be common amongst patients living with HIV, especially as they are hospitalized and transition into the hospital and back out again. A systematic review of over 25 studies published between 2000 and 2013 on medication errors among hospitalized patients with HIV infection revealed that the overall medication error rate can be as high as 86%. The range was quite large in this systematic review, but that could be due to just differences in study designs, the training and expertise of healthcare professionals at these individual institutions, the volume of prescriptions for HIV medications at each of these sites as well, and of course the presence of a clinical pharmacist who may specialize in infectious diseases or HIV. What each of these studies found, though, was that the highest number of errors occurred at the level of prescribing, where prescriptions for the wrong drug or perhaps incomplete antiretroviral therapy regimens occurred a little bit more frequently than other types of errors. This study also found that when there was a pharmacist who was leading medication reconciliation and or stewardship activities within the institution, there was a reduced rate of antiretroviral therapy medication errors. And that brings up an important point about the role of antiretroviral therapy stewardship in patient practice. Recently, a joint policy paper was published from the Infectious Diseases Society of America, HIV Medicine Association, and the American Academy of HIV Medicine endorsing the use of antiretroviral therapy stewardship in our hospitals, saying that coordinated interventions designed to improve the continuity of care for patients receiving antiretrovirals through the utilization of evidence-based ARV practices, including reconciliation, looking at dosing adjustments, mitigation of drug-drug interactions, and prevention of viral resistance. These types of activities can be key to ensuring that there's safe medication use for our patients living with HIV as they transition into and out of the hospital. Now, some of the activities that can be performed as part of a stewardship program can occur at hospital admission, throughout hospitalization, or even at hospital discharge. Ideally, activities are occurring throughout the hospitalization. Starting with admission, certainly looking at a medication reconciliation type of activity, obtaining a complete ART history, assessing adherence, insurance information, ensuring that the prescribed regimen for the patient is correct as they enter the hospital, ensuring that we're using the appropriate formulation, whether it's a liquid formulation, the tablet formulations. Do we have to consider crushing the medicine? And of course, we want to make sure that we're mitigating drug-drug interactions as patients enter the hospital as well. Now, during hospitalizations, we want to make sure that patients are getting their antiretroviral therapy every day and not missing doses for one reason or another. So we want to assess the medication administration record on a daily basis and try to mitigate any issues that are occurring with antiretroviral therapy, including things like drug interactions, adverse effects, again, checking in on that formulation to make sure it's the correct one for the patient and that administration is going well for the patient too. And then on discharge, of course, we want to make sure that the correct regimen is being dispensed to the outpatient setting, that the patient will have access to this medicine, that they have clear instructions and education about the medicines upon discharge, that we make sure that they have assistance programs in place if necessary, and that we, again, finally make sure one final time that there are no drug-drug interactions as patients are leaving the hospital. Putting all of these activities together can make sure that a patient has safe medication use throughout their hospitalization. Now, certainly one of the most important things that we need to consider is a change in renal function as patients are hospitalized and maybe throughout their hospitalization. And we know that some of our medications for HIV are subject to dosing adjustments when renal impairment occurs. And really, we think about the nucleoside analogs as being the most commonly affected medication class when it comes to renal adjustments. And for our patient who is on darunavir, cobicistat, TAF, and FTC as a single tablet regimen, if our patient experiences renal insufficiency, we may need to break up that regimen and ensure that they receive the appropriate doses of each medicine, including those that FTC TAF component, if they have that renal insufficiency. Another important consideration, of course, is hepatic impairment. At times, there may not be a lot of data to direct our interventions, especially if someone has severe hepatic impairment. But there are certain antiretrovirals to think of and maybe adjust the dose or avoid maybe certain antiretrovirals when someone has mild impairment or even moderate impairment of their liver function. Some antiretrovirals may require even dosage adjustments in mild impairment. This includes the abacavir-based regimens. In moderate impairment, a lot of medicines still may not require dosing adjustments, but there are now more medicines that may need to be contraindicated at this level. And then at severe impairment, again, a number of medicines that may not be appropriate for the patient, not recommended or contraindicated, but also many that haven't been studied and the data is just not there for us to make decisions. Then, of course, drug interactions are going to be important as someone enters the hospital and stays within the hospital and then gets discharged. We want to be thinking about drug interactions to make sure our antiretroviral medicines are working as well as possible and we're not experiencing any toxicities. When we think about our patient entering the hospital on, again, darunavir, cobicistat, FTC, and TAF, at least when looking at the medicines that a lot of patients may encounter commonly on the inpatient side, things like proton pump inhibitors, histamine receptor antagonists, antacids, and other common medicines, you may not see a lot of interactions with boosted darunavir. However, we may see interactions with other antiretroviral medicines. Certainly, when you think of proton pump inhibitors, you should be thinking about atazanavir as a medicine that will have reduced concentrations as a result of being administered with a PPI. Same with rilpivirine. That medicine and PPIs are actually contraindicated. Rilpivirine and atazanavir are both requiring an acidic environment for adequate absorption. Certainly, there would be concern there then for histamine receptor antagonists like famotidine, both with atazanavir and rilpivirine, as well as antacids. And then, of course, the integrase inhibitors are subject to chelation types of interactions with polyvalent cations. So thinking about multivitamins, iron supplements that are administered orally, or antacids. We want to separate the administration of our integrase inhibitors with those types of agents. It's not that they're contraindicated, but separating the administration by a couple of hours will allow those integrase inhibitors to be absorbed properly. Now, our patient is being admitted with potential atrial fibrillation, new onset AFib. And so, thinking about some of the medicines he may encounter, we do need to be concerned with our boosted darunavir based regimen. So, if the patient were going to be started on an antiarrhythmic, some of the antiarrhythmics may be contraindicated with boosted darunavir. Certainly, some of the anticoagulant medicines, the oral anticoagulant medicines, certainly would interact with darunavir, and potentially darunavir increasing that risk of bleed that may be associated with those agents. And then warfarin, another anticoagulant agent that you might be thinking of, not contraindicated with darunavir, but one in which there would be a potential interaction where monitoring that INR and adjusting the dose of warfarin would be essential. And so, kind of summarizing the common medications on the inpatient setting that you might want to be concerned with your antiretroviral therapy, thinking about those polyvalent cations, certainly with our integrase inhibitors, our acid-reducing agents with drugs like rilpivirine and atazanavir, then thinking about beta blockers, calcium channel blockers, our antiplatelet agents like clopidogrel and prasugrel. These are prodrugs that require activation, metabolism really to be activated to their active forms. And sometimes our boosters or protease inhibitors may inhibit that metabolism and inhibit those drugs from being converted to their active forms. Anticoagulants, of course, another medicine where, a low therapeutic index, where any increase in the concentrations of those medicines from a booster or protease inhibitor may increase the risk of bleeding associated with those drugs. Antiepileptics, especially older antiepileptics, phenytoin, phenobarbital, strong inducers that may reduce the concentrations of many of our antiretroviral medicines. Then you need to think about drugs like antipsychotics, certainly antifungals, maybe rifamycins, very strong inducers as well. Corticosteroids can be an issue, especially dexamethasone, a higher dose or a prolonged dose or use of that medicine with induction properties as well. Narcotics and benzodiazepines. All of these drug classes seem to be quite common amongst patients admitted to the hospital and can be difficult to manage when someone is also on their HIV medicines. And then we also want to think about some of the food effects on antiretrovirals as well. Some medicines that we use can be taken without regard to food. Drugs like bictegravir, doravirine, dolutegravir, raltegravir. Oral bioavailability is quite good and it's not altered by food. Other medicines really should be taken with food. A lot of our protease inhibitors should be taken with food. The elvitegravir-based regimens, rilpivirine for sure, should be taken with a certain amount of food. And that's because food improves absorption of these medicines. And then some medicines you may want people to take on an empty stomach. Certainly, we think of efavirenz being in that category. Food increases efavirenz absorption, and that may actually increase the adverse effects associated with that medicine. So avoiding food in patients on efavirenz would be key. Then lastly, thinking about patients who have swallowing difficulties. I think a lot of times we deal with situations where patients have changes in their oral access. Do we need to think about crushing medicines or looking for a liquid formulation in order to try to continue administering antiretroviral therapy medicines to these patients? And fortunately, we've seen an increase in the number of agents over the years where we have more data on whether or not we can crush these medicines and to administer them via PEG tube or perhaps nasogastric tube. And so a number of nucleoside reverse transcriptase inhibitors, protease inhibitors, as well as integrase inhibitors may have data for crushing. Our patient, of course, being on darunavir, cobicistat, FTC, and TAF, we do have evidence that that medicine can be crushed and administered in that type of formulation. If we are looking for a liquid formulation, the options are a little bit fewer. Certainly some of our NRTIs like abacavir, FTC, 3TC, those are available in liquid formulations. Some of our protease inhibitors as well, atazanavir, darunavir, lopinavir, and ritonavir, all available as liquids. And then some of the integrase inhibitors are available as powders or granules, but those are really indicated for pediatric patients. That includes raltegravir and dolutegravir. And then, of course, there are a number of tablets that we cannot crush and sometimes capsules that we cannot open. But again, a number of medicines that we use very commonly. We have more data and more options now for patients with swallowing difficulties. Now we're going to hear from a patient who has HIV infection and was admitted to the hospital and was receiving her antiretroviral therapy.
Most of my meds were having to be crushed up. Now, mind you, a lot of meds can't be crushed up, but they were being crushed up in order for me to take them. They were putting them in puddings and all of this kind of stuff. And for a long time, I did not like chocolate pudding, vanilla pudding, or lemon pudding, any kind of pudding, because they all had my meds in it. And it's like, I can't stand pudding. But that's how I was having to get these meds down that were not supposed to be crushed. But this was the only way to get them in my system. So started doing that so I could start to get better and start my throat on to healing and, walking and all of this kind of stuff and talking and all of this kind of stuff.
And so to summarize the take-home points from this presentation, we know that patients living with HIV can accumulate medicines over time from different care providers, as well as when they transition into the hospital and have other transitions of care. This can result in polypharmacy, increase the risk of medication errors, as well as drug-drug interactions. Patients with HIV hospitalized may encounter new renal or hepatic considerations for their ART or new drug-drug interactions. We must consider food effects as well as swallowing considerations with ART in order to make sure that we're using the correct formulation of the medicine and achieving adequate absorption of our medicines. And multidisciplinary antiretroviral therapy stewardship programs can really reduce medication errors during transitions of care and ensure safe antiretroviral therapy practices. And so for more information, please go online for more CCO activities on key decisions in HIV care.
Thank you to Dr. Schafer, and thanks to the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.